Audio Jungle. Audio Jungle.
Okay, thanks. My name's Simone. I'm a physiotherapist based in Adelaide, and I'm presenting today on behalf of Invacare. So I was working for Invacare in South Australia, running their seating and mobility clinic, and I've now branched out on my own. So today we're going to just spend 45 minutes helping us just to think about how we, link that, what we see with our clients and from our assessment, and what sort of seating products we use and put together to create seating systems for our clients. So thinking about what the possible outcomes of seating and positioning are when we go into it, what are the things we're wanting to do? We're wanting to look at balance between stability and mobility in the seated position. We're wanting to think about how we maintain and support the skeletal alignment to prevent deformities. We want to maintain and improve tissue integrity, enhance circulatory and respiratory function, and maintain comfort or provide a comfortable seating system for somebody, and also decrease fatigue. And I'd like to think that basically in all the systems, pretty well without fail, certainly the tissue integrity, the respiratory and circulatory function, and comfort are almost givens, that we would provide those to the maximum of our ability in any seating system. The other systems, or the other points, it depends on the person's function, their ability to move themselves, their ability weight shift will still need to be thinking about those things, but the relative importance of it, or how much external support or how much the seating system might have to do to provide that, will vary a little bit. So continuing on, another couple of outcomes, so these just didn't quite feel that they're all the same thing. We then also want to think about allowing the person to be as functional as possible. So where someone's got function, that seating system should absolutely maximise that, and I'm sure you've heard that in lots of different presentations so far. If someone's not quite as functional, we also then want to make sure that the seating system facilitates, or it's easy for the caregiver to also operate and work around, so that it needs to also provide that support for the user, but it also needs to work for the caregiver. Okay, so I'm sure that we've heard before that the pelvis is the cornerstone for the seating, so it's what's underneath us when we're sitting. I'd like to take that a little step further and think that we want to start to think about it, that it's really optimal support of the pelvis that's the cornerstone to all seating solutions. So that pelvis is there, but it's in how the seating solution comes in and supports that pelvis in whatever position that's in and whatever availability. We'll talk through some of the things a bit further on. But that's what's important about our seating system. So basically knowing where to provide that support, there's a lot of research out there in the literature, so ergonomic research and seating literature that helps us sort of to provide some guidelines for that. So we're going to look at some of the basis from that, and then we're going to broaden it out and think about how we're going to need to adapt that for our clients. As we know, most of the ergonomic research has been done with cohorts with relatively normal and intact neuromuscular systems. Okay, so providing support in seating. What are the things we need to think about? So firstly, we need to respect the skeletal shape. So the position for it, or the way those bones and the tissues around it are positioned, are within a limit fixed for a person. So we need to make sure we respect that in any sort of system that we're putting together. So we need to be able to respect it, we also need to understand what that system, what that looks like, that shape looks like for any individual, and that's where a really good assessment comes into it. And then we want to utilise key support points. So we're going to talk a little bit further then about what those key support points are. And this will then have implications for intact neuromuscular systems versus damaged neuromuscular systems, and the things we need to think about then will vary slightly depending on that. So looking at skeletal shape, the key thing in the sort of fairly neutral sitting position for somebody who's got good range of movement, the fact that our ischial tuberosities sit at about 1.5 inches or 3.5 centimetres below the other bony surface of the femurs. So we need to make sure that the seating system then respects that and allows for that. Otherwise, if we don't do that, we're going to get a concentration of pressure under the ischial tuberosities. So we also, another implication of that is a cushion that's less than that 1.5 inches won't allow the ischial tuberosity to sink in without bottoming out. You'll then be coming through onto that firm surface that's underneath, and you'll be causing that concentration of pressure through the itates. So it's something that we want to avoid. Also in this position, in the skeletal shape, we've got how the pelvis sits, so the position of the sacrum, PSISs and the ASISs. And then leaving the pelvis, we've got the lumbar spine. So in an upright, when the pelvis is well supported and in a flexible position, or in a situation where the person's got reasonable flexibility and range of movement, so relatively good joint ranges, see here that the lumbar spine leaves in a lordotic position. So we're wanting to think that that's our normal position. However, as we all know, that there's we're not going to be able to achieve that any time, all the time. Sorry. So thinking about how we need to go about identifying musculoskeletal change, so what sort of things we want to make sure we're covering in our MAT assessment or in our assessment of our clients when we're prescribing seating solutions. So we want to make sure then that we identify the joint range of motion issues, particularly at the hip joints, the spine, the lumbar spine and thoracic spine. So how much movement we've got, how easily does that move? So not only the actual absolute range, but what sort of stiffness or how easily that is. And we don't want to be trying to put a seating system in that is requiring too much force to hold someone into position. We really need to make sure that we're positioning someone where there's just a minimal amount of force required, so they're as balanced as possible. So we need to know what range of movement they've got. We need to look at muscle tightness. We need to know what their weaknesses are like, how much ability do they have to actually move themselves within the seating system or to control their posture if they move from one position to the other. Does the seating system then not need to provide as much external support? So key factors, we want to think about making sure that we definitely know what our hip flexion range of movement is. We need to know our hip abduction and internal rotation ranges in terms of how then that's going to work on the pelvis from a seating position. And as we've said, we've talked about spinal movement as well. So here's an example of our MAT evaluation. So at first glance, you might well think that person has 90 degrees of hip movement on their right leg, so they're supported there. But if you look then at what's happening here in the left leg, you can see that to get the hip up into, or the femur up into that position, you can see that the left leg's actually started to flex there, and that the pelvis is tilting posterior, which probably indicates then that in fact they don't have 90 degrees of hip flexion on that side. So we'd be wanting to then make sure the seating system respects that. If we then try to fit that sort of person into a chair which has 90 degrees between we won't say seat and back angle all the way up, but certainly the seat and the pelvis area, that person's not going to fit in that. What are they going to do? They're going to have to slip forward to then be able to sit in their range of movement. So we need to really understand what we're working with to know in our heads then as we start to think, well, how we're going to set up that seating system, what we're working with. The other thing that's quite interesting to note in this, that's useful information sort of from a MAT eval, is that this person, the fact that in supine looking at what's happening to their back, so they've actually extended quite nicely, so they're lying quite flat on the bed there, so it looks like their thoracic spine has actually extended quite nicely. If you see a picture of this person sitting up, they're actually looking quite kyphotic, quite slumped, they're actually quite weak. So it's really handy to know from a MAT eval as well what that range of movement is and what sort of flexibility is available there. So when we're looking at someone, so trying to understand what we're working with, it's really important to consider the three different positions. So we've talked about our supine MAT eval. It's always interesting to look at someone in their current seating. I think that's always where we're going to get our first impressions. As someone comes in, we see how well we think they're functioning, how they're sitting, but then also to understand, are they sitting like that because their current seating system is forcing them into that position if it's less than adequate? Or alternatively, what's the seating system doing that's supporting them well? So we can learn quite a lot from someone's seating system, even if it's not optimal. Can also give us, for an example, we can look at the person in the seating system. We can also look then when they hop out. It's always a good idea to look at what's the cushion look like when they sit in. Is there a dip underneath under where the IT sits? So has there been more prolonged pressure under one side? So would that make me start to think about a pelvic obliquity? So all of those things give us really important information. And then lastly, we also want to have a look at someone sitting with no seating system. So that's not just putting someone on the edge of a plinth and leaving them. Obviously people will need some support, but just seeing how they then start to respond against gravity in an anti-gravity position, what they do, what sort of postures, what sort of movements they achieve. And also then starting to experiment with how do they respond if I start to correct them a little bit or provide some input. Do they like, how do they tolerate correction or what I might be wanting to do? So it's really important to compare all three positions. Okay, so let's have a bit of a look of some biomechanics. Just look at what happens to the pelvis in sitting. So when we're standing, the centre of gravity is basically balanced over our feet, so the weight bearing comes up through the femurs, through our greater trochanters and our femoral heads, and then our upper trunk is balanced over that. As we then move into a seating position, the ischial tuberosities become the new base of support, and so in order to sit then or to be balanced, you need to position your body weight or your centre of gravity over the ischial tuberosities. And for that to happen, the pelvis does have to rotate posteriorly slightly, so that brings those ischial tuberosities a little bit forward to bring them under the centre of gravity. And as this happens, the lumbar lordosis flattens. So I guess what's the take-home point from that is that as provided somebody's got the mobility and the flexibility for that to happen, it's normal for the pelvis to posteriorly tilt a little bit and the lumbar spine to flatten a little bit into a seating position, so that we're not wanting to aim to support someone in as much lumbar lordosis as what you might see if in standing. So the shape of the lumbar spine then is determined by the sacral position, and so it's really key that we use our lumbar spine, our pelvis, rather than the lumbar spine as our key point of support. It's quite uncomfortable to provide support directly onto the lumbar spine, and also I guess there are multiple joints over the lumbar spine, so you're not going to get as good control as you are over using the pelvis. Okay, let's have a little bit of a look higher up. So basically the thoracolumbar junction, so the lower part of the ribs between the T12 and L1 region, has been identified in the literature as being the weakest point in terms of supporting the body and the spine. And so that's a critical point then in the formation of the kyphotic posture. If you see what has to happen in terms to the body, think about what we saw in the more upright position. So to get to this position, that thoracolumbar junction point moves backwards, the pelvis is tilted posteriorly, and then the trunk and head has moved forward. So as well as the formation of kyphosis, or in order for that kyphosis to form, there's been a fair bit of anterior-posterior movement. So there's some things that we can think about these are the movements we want to think about counteracting if we're providing support in a seating system. Once again, bearing in mind if the person has the flexibility and the tolerance to be corrected. If someone has, if we assess that sort of person, we lay them down and they remained much in that C-type curve, well obviously we're not going to be trying to then correct that position. We'd be looking at supporting them in the position they're in. So from all of that, what comes out as key support points that we need to think about? And I would say really in any seating system, and obviously it's going to how they will then present will be quite different depending on the more we need to also allow for people, accommodate people's change in position. But these are the points that we need to think about supporting. So firstly, the thoracic apex or the thoracic spine, we need to make sure that we allow enough room. So it may not, I've written slightly back there, but certainly we need to make sure we allow room for the thoracic spine to move backwards and help to balance that weight of the chest above the centre of gravity. We need to provide support at the low thoracic region, so that weak point of the thoracolumbar junction. It's important to provide support there. And by providing support at this, particularly, once again, not so much centrally, but over the sides of that point, helps to then extend at the spine, the thoracic spine, and in doing so, elevate the sternum, which is really important for respiration, and we'll cover that a little bit further. So support it, and then a bit further down the PSIS, supporting at the PSIS then will prevent that further posterior pelvic tilt. So we've talked about we need to, if someone's flexible enough, we need to allow that pelvis to posteriorly tilt a little bit, but then the aim of the seating system is we want to prevent that going any further. So we need to provide that block and that support there. So once again, as I said, it's important critical to understand the patient's or the client's hip range of movement and also their lumbar spine flexibility, and that will help us to really determine at what point do we support that pelvis, or how much of that critical posterior pelvic tilt do we allow to occur, and that will be dependent on the results of our assessment. So a lack of posterior superior iliac spine support then can just allow that pelvis over time to sag further. So we all know what else other than the external supports, what normally provides our support for the body in the upright position. So it's either our muscular system, so our tone, or our ligamentous structures. So we know that someone that prolonged sitting in a position is quite tiring, that our muscles will switch off. So that means we're then relying on our ligamentous structures. If we don't provide that external support, our ligamentous structures will be the ones that are bearing all the weight, and that over time is what's going to cause postural deformities. Okay, further down, providing support at the posterior buttock. So looking for providing in the cushioning surface or our seat cushion a lip or a bit of a raise at the back of the cushion, so it comes up and provides a bit of support behind those buttock tissues. Also will help to just reduce that posterior pelvic tilt. Okay, we talked about ischial relief, so the need for the cushion or the seating surface to contour the bony structures, and so some form of relief, either a lesser foam or a lesser density of foam. There's different ways that that's achieved using an air cell surface. So there's lots of different products out there or different ways of achieving that ischial relief, but it's important that if someone's going to be sitting for a prolonged period of time, that cushion must respect that anatomical structure and provide a relief there. And then finally, use of a hip belt, or some means, there's a hip belt may or may not always be used, but some means then of counteracting, I guess, that all of the other support surfaces are posteriorly, so we may need something then to stabilise anteriorly and stopping the body moving forward, because a support surface, I suppose, is only helpful as long as we maintain that position. If we provide a support surface but then there's nothing to stop us moving away from it, we'll then potentially lose that support. So that's where a hip belt anteriorly can assist in preventing posterior pelvic tilt. Okay, so here's an example of a cushion that's been designed using, I guess, an anatomical basis. So you can see there's an ischial relief for the ischial tuberosities to sit into. The rear of the cushion curves back up. Once again, the greater trochanters are quite nicely supported, so the leg troughs extend further back, so we're supporting those femurs all the way back there. And also importantly, you can see here the position of the backrest is such that it's supporting those PSISs. All right, so what are the things we might need to think about of supporting the pelvis if we haven't got a pelvis that can be into a neutral position, or it won't sit flat on the cushion that we've just got? What sort of things can we do? So firstly, a pelvic obliquity pad. If one side of the pelvis sits higher than the other, we might think about putting a pad into the cushion to support that, and that will depend on which side we choose will depend on how much flexibility or otherwise is at the spine and in the whole system. If someone is able to be corrected and we can bring them back into more of a neutral position, then we might put that pelvic obliquity pad, or most likely put that pelvic obliquity pad under the lower side to help to tip them back, bring them back into a neutral, so that will give them a neutral base to sit on. If that range of movement's not there, then we'll need to support under the opposite side. So that will then mean that we're equalising the weight-bearing surface. So once again, giving that stable base for people to sit on. Okay, in the case of a rotation at the pelvis, we might need to think about a leg length cut out of the cushion to make sure that we are, two things, I guess, maintaining support, but also not then using a cushion that becomes relatively too long on the short side. So if the cushion is too long, if we didn't have a cutout here and this side of the femur was then expected to sit down there, we're going to be pulling that pelvis into posterior tilt. We can see then associated that we still need to think about supporting the PSISs, so that will mean either, as is done here, having a backrest where we can actually use the bracketry and the mechanism of the backrest to rotate that and adjust it, or if that's not possible or we can't gain sufficient movement there, we might actually need to put some insert in behind the PSIS or behind the pelvis on that side to make sure we've got good contact and we're supporting that pelvis even though it's in that rotated position. So the position of the pelvic belt, we can sort of adjust that quite a bit to really give the to provide forces and help to correct the pelvis as we need to. So we might want it more of from a higher angle, so more towards a horizontal position if someone's pelvis tends to sit more in an anterior position and we want to provide a bit of support there. We might bring it more horizontal, or if they're to prevent that posterior pelvic tilt, we might use a sort of a 60 degree or even down to a 90 degree to provide that anterior support. Another thing we might think about doing if someone has a unilateral hip flexor tightness, we might think about doing a cushion that is then cut away on the tight side. So if someone's only got sort of say 80 degrees hip flexion on one side, but they've got the 90 on the other side, keep the cushion at that 90 degrees on the side with the greater movement and cut away the forward side of the cushion, so that allows them to drop down, so that hip restriction then is not acting on the pelvis, still keeping, but it allows for that range of movement change. The other thing to consider is that the ITs might not be able to sit from a front position or a lateral position. The ITs might not be able to be positioned directly under the centre of gravity, so we might need to think about offsetting in a lateral direction as well, so also setting the backrest to one side or being able to move the cushion to one side, so we won't necessarily be able to set them up directly one over the other and from a front position. Oops, sorry. Okay, so that's sort of looked at the question. Let's have a look at the back supports and how the back support can assist us to stabilise the spine and the pelvis. So I guess the main role of the backrest generally would be to support and position the upper body to gain balance and function in a seating system. I guess that's what we think about the main role of the backrest generally. But I guess we also really want to think that it's a key role of the backrest is to provide that PSIS support and yes, help to stabilise the pelvis. So it's not only an upper body support, it's also got to help us to stabilise that pelvis as a cornerstone of seating. Okay, so there's lots of different choices out there in terms of what different backrests we can choose, and so how do we look at what we might need to take into account when we're choosing a back support for that posture or that person that we're seating. So we need to consider the height, the width of the backrest and the radius of fit, so how snugly or otherwise it aligns the side of the body. What contour depth, so how deep between the centre of the backrest and how far forward does the support come. What angle we need to set that backrest off, so a lot of bracketry nowadays has the ability to adjust the angle in a tilting position and also forward and backward, so how we can make use of that. I mean, I think we'd probably all agree that that's really been one of the huge advances in sort of off-the-shelf seating, being able to use that sort of bracketry and adjust that really makes such a difference for how we can actually position our clients. And we've also spoken about then rotation, so the ability to position one side of the backrest further forward than the other side. So having a look at heights, we've talked about the fact that the backrest then a key function of the backrest is to support that PSIS, but how then do we make decisions about how far up the backrest goes? So we have a range of options. How do we decide what height we need to use for a particular person? So we can start the low when we would choose, so a lower backrest that will finish at the low thoracic spine or the bottom of the rib cage will then provide a bit of a support surface to lean against. It will then help to stabilise the lumbar spine and give support. So an example of this might be, there's a few different examples of backrests that are used that sort of positioning. Moving further up, we might want to look at the height of the bottom of the scapula, or a backrest where the lateral support comes to the range of the bottom of the scapula, but it may actually, the middle of the backrest might be a bit higher. So there are backrests, thinking about a backrest that has a cutout for the scapula and arm, so we can get some of that central support for someone who needs a bit more stability from their backrest, but we can still have that with the arms freed up and the scapula mobile to allow for upper limb functioning. Okay, we might move slightly higher up again for someone who we see, this type of client that will tend to then tip over backwards or angle over backwards in a less supporting seated system. So once again, we might bring that backrest up to sort of the spine of the scapular region there, but also then still being cognizant or aware of the amount of function they need from their upper limbs. And then the top line represents then full back support, so it's typically for somebody who has a tilt in space system, so where as they tilt back in the chair, that the backrest actually becomes more of a weight bearing or more of a support surface, so we need to make sure that that weight is distributed up the back, so they will use those sort of backrests that come to the full height. Another time when we might think about using that is if in a case of where an anterior support is required, so either for transport or for positioning, and we need to then make sure that the attachment points of those, the harness, the chest harness or chest support, are able to be supported. One thing to think about then is the taller the backrest, it's really quite critical that the angle that we set it on then. So we mentioned that one of the key things in terms of the supports is that we do respect and allow space for that thoracic spine. So the higher up the backrest we move, so really once we move sort of beyond that bottom of the scapula, or really once we move to that point of providing support above the apex of a normal thoracic curve, we really need to make sure that we're getting the angle of the backrest right, so that we're not then pushing someone forward and forcing them further into a kyphotic position or tipping them out of their balance point. So thinking about even with someone who has then quite a fixed thoracic kyphosis, where we're needing to allow a reasonable angle between the seat and the back. So we might need to angle the backrest there to allow space for that thoracic cage. We might still then need to think about putting some additional support down a bit lower, so we're actually still getting that PSIS support. So just because they've got a bit of a kyphosis, particularly if it's a bit of a lumbokyphosis, we may still in fact need to build up around that PSIS level to make sure we are still supporting that pelvis in the position. Okay, so I've talked a bit about there. All right, so just the bottom left picture there is a nice example of how backrest height also can impact on somebody's function. So this is a fellow with a spinal cord injury with a 12-inch backrest, and you can see with that he's still quite functional. He can reach around and grab something from the back of his chair or talk to somebody behind him. If the backrest gets much higher in that situation, he'll actually be restricted from doing that. Okay, so what are the long-term impacts then of not providing adequate support for someone? So we can see this fellow's a really good example. So this is the postural changes that we spoke about before, but then it affects a wider range of body systems. So this fellow then has developed problems with his cervical spine. He's got nerve entrapment in his cervical spine from the fact that his upper body, his thoracic cage is flexed so far forward, his cervical spine then hyperextends to compensate for that. He's developed some nerve entrapment as a result. There are issues with digestion. He's also got pain. He's had issues with pressure. So we can see that these are all things that we want to help prevent. As well as that, being in this position for a significant amount of time has a really big impact on pressure sores. So there's been research to show that that this position is most significant in terms of contributing to pressure sores. So as well as the fact that, so in this position the pelvis is so far posteriorly tilted that the person's effectively sitting on their sacrum and their coccyx, so they're areas where there's really very little covering other than the skin, so they're particularly vulnerable in terms of developing pressure sores. Another region you can see here there is, in this case, the spines of the scapula become very prominent, and once again there's very little fleshy support for that. And so those, in fact, it can, depending on how the backrest is set up, the spine of the scapula in this case can actually become a weight-bearing surface, which is obviously not what we want to see, so that could be really at risk of breaking down. So we might need to think about, in this sort of situation, we might need to think of padding either side of the backrest and allowing a recess for that lumbar and low thoracic spine to unload that. All right, so we've talked a bit about posture and how we've assessed that and looking at what sort of posture and position someone's sitting in, how the pressure is distributed. We then want to think about what effect does our seating position have on somebody's respiration. So yes, and I've heard somebody say who comes from more of a respiratory focus, so they ask why in fact do we put respiration at the bottom of this hierarchy? Do we want to be and do we want to in fact be dealing with dead people? So their argument is in fact that should be a lot higher up the hierarchy than what we've got it here. And I think it's something that there's certainly a lot more attention being paid to the respiratory effects of respiration in seating, but it's still something that needs to be thought about. Okay, so there's a physio in the United States by the name of Mary Massary, and really recommend that you go and have a look at her stuff. She's a paediatric physiotherapist whose interest is on motor behaviours in breathing and postural mechanics. But has done a little bit of work of how that then relates to seating systems. So she likes to use a Coke can as a nice sort of analogy of what how our body functions in a normal situation. So she uses the Coke can, the top of the Coke. So her analogy is that a Coke can, although it's made of quite sort of flimsy material, and so the material itself doesn't have a lot of sort of support structure, when it's intact and sealed, it's actually it has a lot more strength like that. And I guess what she's trying to get at is that with the body in its intact situation, the abdominal and thoracic cavity help to support the spine, but when we start to lose our position, we start to lose a lot of strength and integrity of the system. So she sees then at the top we've got the vocal folds and the thoracic cavity, and separated in the middle then is a diaphragm, below that the abdominal cavity with the pelvic floor being the bottom section. So she's also really brings to the point that the diaphragm in this sort of setting then, we need to see it as much more than a respiratory muscle. So it's certainly the diaphragm that is responsible primarily for our respiration, but also it has a really big role in terms of maintaining postural support, has a role in gastrointestinal motility. So she's got some really interesting points. So if you sort of, I'd certainly recommend that have a look at her website, and she's certainly done some really interesting work. Okay, so just quickly revising the mechanics of breathing, because we want to make sure that we're allowing for that in a seating system. So firstly, it's a three-step process. So the diaphragm contracts and moves down and tightens, which draws then the lungs downwards. After that, the lower ribs then expand up and out in that bucket handle movement. And then thirdly, the upper chest expands forward and anteriorly, so in that pump handle. So we've got down, out and up. So there are three directions that the thoracic spine needs to move, the rib cage needs to move in for normal breathing. So we want to make sure that the seating systems that we're prescribing respect that as well and allow for as much of that to occur as is possible. Okay. So what's the relationship then between the functional positioning objectives that we want with seating and how that relates to respiration? So been shown that a position of lumbar lordosis is key to maximising lung volume. So we've also said that we want the lumbar lordosis to be a more desirable postural position to be in, but also that's then going to have some positive effect on our respiratory system. So that's where, as well as the lumbar lordosis, then that support at the thoracolumbar junction is really critical to help extend through that thoracic spine and then from anteriorly lift up that sternum, which will allow then or facilitate good respiratory mechanics. So that's how we can be influencing respiration when we think about how we prescribe a seating system. So we want to make sure then that the seating system we're prescribing then allows space for that thoracic cage to expand for breathing. So we want to make sure that any external supports or the actual seating itself is not so tight that it's going to restrict particularly the lower rib expansion. As well as that, then positioning the thoracic cage in that upright position allows for position of balance of that head and shoulder. So those vocal folds or that upper cap on that respiratory system or that intact system, we want to make sure that then we're positioning someone so they are able to function and operate and allow then for good speech and respiration. So how the back support influences respiration then, so by positioning someone where we're allowing that rib cage to be nice and open and extended to the best of the person's ability and functional status, we're then promoting expansion of the anterior chest cavity. And this can also be reinforced by abduction and external rotation of the arm, so that will also facilitate this ability to take some nice deep breaths and improve our respiration. So we then provide a back support that's too low, so we've got decreased lumbar support. That means the muscles that should normally be working on respiration, so our oblique muscles and abdominals and our oblique muscles will then need to take over a role of try to provide, I suppose, a support role rather than being able to work on respiration. So if we're someone who hasn't got enough support in their sitting system, the muscles are then going to work hard, are going to have to work just to support that person upright. That's going to then have an impact on or a negative impact on their respiratory system. Conversely, if we position a backrest too high, that's going to then have an impact on, we said before, it might actually flex that upper. We're going to get a depression of the sternum. We're going to flex the thoracic spine. We'll get those shoulders coming forward into protraction and internal rotation, and that's going to reduce that ability of the chest wall to extend and elevate. So how might we think about assessing the patient in terms of or taking that into account? We talked about how we assess joint range and that sort of thing. So basically it's looking when we're prescribing a new seating system or putting someone into a system for the first time or adding extra support features, we want to think about things like the shortness of breath or their change in their ability of speech, so their speech volume. Is if that changes significantly, we want to be looking at, might be looking like it's giving them a really nice support position, but if they're not able to speak as well, we're obviously compromising the respiratory system. Tachypnea, so if are their rate of respiration increasing, or tachycardia, or their heart rate increasing, so they're the things we can think about measuring. Are they using their accessory respiratory muscles, as I said before, to actually hold themselves upright? Are we not supporting them in their balance? So it may not only be lack of support, but it may be that position we're trying to support them in. If they don't feel balanced, we might find that they then start to use their respiratory muscles to try and hold themselves or to try and to embrace a bit, and that will have an impact on their breathing. Okay, so we can use pulse oximetry is a nice simple measure that we can use, and I actually meant to bring up, there's some nice little units that are available now, and there's some downstairs on the Invacare stand, which are just really, they're not attached to big monitors or anything anymore. There's just some really little sort of freestanding units almost that are quite inexpensive these days, that are a handy little tool to have. And we thinking about putting them on somebody before and afterwards, and need to think about sort of leaving it for a period of up to about 30 minutes, just to allow someone to settle into the system, and just monitoring to what their doing in that time. All right, let's have a quick look then at just a bit of a case study here. So we've got the fellow. So if we look at the slide on the left, we can see that he's got a mild pelvic obliquity to the right. The right side's a little bit lower, but he's then leaning over towards the left. His spine looks like it's curved over towards the left with the right shoulder being markedly higher. He's holding onto that armrest. From the lateral view, then we can see that his chest is, the posterior part of his chest or the apex of his spine is sitting well, looks like it's well behind his pelvis. So what are so if seeing someone there, what are the sort of things we might be starting to think about then is we might start to think that they've got a fairly significant scoliosis happening. We might think that they're quite posteriorly pelvic tilted. We might even think there's a bit of extensor tone possibly happening, looking at where his feet are positioned, particularly in this slide here. So they're all things that we might be starting to think about. However, when we get him out of that seating system and put him onto the plinth, this is in fact what we see. So in this case, it was the hamstrings. He's got markedly tight hamstrings. So it's a real example of the fact that that seat depth of that wheelchair was way too long for him. In addition then, there's quite long or lower angle hip leg rest hangers forced him out, providing all that tension on the hamstrings, then forced him into that posterior pelvic tilt and into a slumped position. So you can see that in free sitting, his obliquity is actually in the opposite direction. He has a bit of a scoliosis, but certainly not as pronounced as it might have looked initially. So another factor with that, the wheelchair that he was in was obviously way too wide, so he was leaning over onto that armrest to find some stability. All right, so just quickly thinking about what sort of frame adjustments we might need to think about then to allow for the postural changes we find. So we might need to think about an increased frame depth if someone, particularly in the case that someone has a fixed kyphosis, to allow for that space for that thoracic spine. Once again, then deciding whether we still need to provide some support lower down over the pelvis. Or conversely, the fellow we've just seen, do we need to sit the cushion or the seat further? Do we need to shorten the seat depth or have the edge of the cushion sitting further in the frame, so to allow those knees to sit in a more flexed angle, and then therefore that frees up that pelvis and allows him to bring the rest of his body into a much better alignment? Do we also need to looking at a lateral component, do we need to think about some extra frame width if there's some wind sweeping or the distance between the side of the chest on one and the knee on the other side is increased, and we can't, and that provides then the most optimal position for that person's pelvis and trunk. We then need to make sure we script that chair up with a wider frame width to accommodate for that. Okay, as well as positioning of the seating system or the angle between the backrest and the cushion. There's also these nice interesting studies looking at the use of anterior tilt as a way of helping people to achieve a lumbar lordosis and then a more upright position and to be functional in that position. So obviously you wanted to be using that. It's probably wanting some sort of system where it's using the tilt in space, so the person could tilt themselves then forward to be functional, come into an upright position, do whatever they need to, and then probably they would then tilt themselves back into a level or a slightly posterior tilt for rest and in between times. So when we're thinking about utilising these strategies, we want to make sure that we know that somebody has got that range of lumbar movement though, because otherwise if someone doesn't have the range of lumbar movement and we start to tilt them forward, obviously it's just going to topple them forward. So really what we want to make sure is that we're not letting our seating systems do this to our clients. We want to use our skills in assessment and how we think about different options we've got available to us to support our clients and to achieve the best position and function as we can. Thank you.